It's been up for 12 years now. We're, I think, just applying for our third waiver. We've been able to maintain coverage. We've been able to maintain quality. I'm not saying it's perfect. There's definitely improvements that can be made. We're so far ahead of any other state in the ability to expand and maintain coverage, because healthcare is the second largest item in the general fund budget. So when it goes up, it squeezes out our ability to invest in education and public safety and economic development and environmental stewardship. So it's really important. I think the biggest threats to the CCO model are that people don't understand it. People don't remember why we did it. People don't understand the pressure that it's taken off the general fund and the number of Oregonians, particularly low-income Oregonians, women and children, single adults who are working, now can actually not have to worry about where their health care is going to come from. States around the country are looking at Oregon right now, because I can tell you that our economy in Oregon, as it was in 2011, is being propped up by federal dollars, and our healthcare system is being propped up by federal dollars. That's going to end at some point. And we're in much better shape than anyone else because we know how to actually manage those costs. The concern I have with the health authority on this is that they tended to view the CCO more as in a traditional insurance lens. I don't want to get too far in the weeds, but it's called a rate-based system. So basically you set your rates based on what happened the year before. So if you didn't spend that much, your rate goes down. Spend more, you get a little bit more, right? So it sort of takes what we did in the past and locks it into the future. I call it a rear view approach to policy making. Doesn't make a lot of sense. The idea with a CCO was that we would give them a budget and a set of outcomes. They needed to manage inside that budget and produce the outcomes. That's what's created the innovation. That's why the Eastern Oregon CCO is so much more different than the one in Portland or the one down in Eugene, right?
We can't just look at the state as a whole. That doesn't work. We know that doesn't work. We've tried that before in Oregon and it didn't work. So what the CCOs allow us to do is to look at our community and say, this is what our community needs. And we do that by talking to people in our community, talking to stakeholders, talking to community members, understanding their needs, looking at our community-specific data, and then making evidence-based decisions on that information is what we need to be able to do. So that flexibility is absolutely critical. Without it, the CCO structure is not going, it won't work. And that flexibility is also what allows partners to come together and really collaborate and build together. And that's what the CCOs are about, is communities working together to get better health outcomes.
Silos between mental health, drug and alcohol, dental and physical health are being broken down with significant savings being realized. I strongly urge your aye vote. Thank you.
There's a quote I love from a writer named Joel Baker, and he said that vision without action is merely a dream. Action without vision just passes the time. But vision with action can change the world. And that's what the coordinated care model is doing. It's changing the world of how we deliver healthcare services in local communities and across the state of Oregon.